and welcome to Connecting Citizens to Science. I'm your host, Dr. Kim Ozado, and this is a podcast where we explore global health and development. Across 2026, we've been putting a spotlight on equity. Who benefits from progress? Who is still being left behind? And what does it take to make health systems work better for the people that they are meant to serve? And today's focus is global oncology. Cancer is often discussed through the lens of scientific progress, talking about new diagnostics, new treatments, and new possibilities for care. But behind that progress is a growing question about whether health systems can keep pace with need.
I think the good news is that people are getting older. And the issue is that also means there will be more patients diagnosed with cancer, especially also in low and middle income countries.
This challenge becomes even sharper when we think about equity. It's not only about what is possible in cancer care, but whether people can access that care in practice, and whether systems are financed in ways that make that possible.
The major issue now faced around the world is fair and transparent financing for strengthening cancer systems.
In this episode, we ask what equitable cancer care looks like in practice. How can cancer systems be strengthened in ways that are locally led, evidence-informed, and responsive to the communities they serve? Joining me today are Professor Eva Kantelhardt and Professor Richard Sullivan. Eva and Richard, welcome to Connecting Citizens to Science. We're really excited to have this debate today on global oncology. So I think let's start by helping both me and our listeners understand global oncology a little bit more. What do we need to know in terms of current innovations and challenges in this area?
Yes, good morning. My name is Eva Kantelhardt. I'm Professor for Global Health, and I'm also a gynaecologist working at Martin-Luther-University in Halle, Germany. I think that especially in countries which have not yet experienced a high burden of patients with cancer, they are now facing an increasing number. And in such countries, health systems are already burdened and strained, and they do have limited resources. So the challenge is how to integrate cancer care into this health system which is existing. We have seen that there is very individual challenges, starting from early detection, from diagnostic services, from treatment, as well as survivorship care. I think that innovation at the moment is very much in the area of like e-health technologies, artificial intelligence. And I can see that there are certain areas where this fits in very well. We have, for example, seen that virtual pathology as well as diagnostic services with artificial intelligence are something that can really be implemented. And that is something that can be done also in low resource settings. And it has started to being utilized in some areas already.
That's a great snapshot. Thank you so much. So innovations around e-health and AI, pathology, and that whole kind of treatment pathway is what's being looked at. I think it's really interesting as well, Eva, that you have raised the importance of countries struggling with their current health systems, but the cancer care is growing and the need for it is growing quickly. So Richard, please help us build on that.
Yes, absolutely. I'm Richard Sullivan. I'm a Professor of Cancer and Global Health and Director of the Institute of Cancer Policy at King's College London in London. I just want to pick up what Eva was saying about the burden. So not only is the burden increasing for a lot of these emerging transitioning economies, but the transitions they're going through are completely unique. They're totally different from what we went through in the Western world. They're dealing with this kind of what we call a double burden of disease, where they're getting not just cancer and other non-communicable diseases, but they're still dealing with infectious disease, relatively high child and maternal mortality. So it makes their transitions much, much more complicated. We're also seeing a huge and massive increase in technical advances in cancer, whether it's chemotherapy, medicine, surgical technologies, radiotherapy, pathology. And that's being felt across all emerging economies. And of course, along with that goes huge public expectation. There is an expectation that these countries' patients will enjoy the benefits and fruits of this massive innovation that's taken place over the last 50 years. But as Eva said, on the other side, we've also got this incredible multi-speed world. We often talk about cancer control in low and middle income countries. which when you think about it is pretty meaningless. You're putting Chad and China into the same group. And even within individual countries, there's a huge difference in transitions. When you look at the demographic leviathans like Nigeria and India and Brazil, the differences between the transitions in individual states in those countries is huge. And each country now is having to grapple with this polycrisis, permacrisis world. So it's not just cancer that's stressing the politics and the financing and public expectations. It's climate change. It's resurgence of infectious diseases. So what we see is obviously cancer is a major burden, social, clinical, economic for countries at the same time as lots and lots of other things going on, and these incredibly rapid transitions, which means that it's very hard for the politics and policy to catch up with them.
It sounds huge. And I think what's interesting here is that you brought out how every single country is unique in their delivery and their health system. So it's definitely not a kind of one size fit all, and we can't roll it out that way or even think that way. And we're used to thinking like that in global health and understanding that I think more and more we're talking about locally led bottom up systems as well. But Eva, perhaps you could talk a little bit more about that and how you're managing these competing priorities for health systems and how you've been navigating that with your research.
I really have the pleasure of collaborating with colleagues from sub-Saharan Africa across very many disciplines and across many countries. And this has really leveraged a lot about how we think about how the systems could be changed, because there are overarching themes as well as very individual problems, as Richard has really nicely pointed out, I think. Our approach is to really go for participatory research. And I can say, we are here in Halle also part of the international collaboration for participatory research. Together with the African colleagues, we really think that there must be an African-centered, community-driven approach to actually improve cancer care. And we have started co-creating interventions, because there's one thing to have a solution, but the other one is to bring it to the people and have the people accept it. There must be evidence about effectiveness, as well as, of course, people and communities taking it up. We have done quite a number of research within the African Cancer Registry Network. For example, we had 15 or up to 20 cancer registries in 20 countries where we looked into access to care. We interviewed patients, and we really found out interesting points that within countries there are huge differences, but also across countries, like in higher income countries like Gabon, there was a very considerable access to care, but patients said that acceptability is really a problem. They had fear. And obviously, there must be more culturally adapted explanation, information, and counseling of the patients. Of course, accessibility also highly dependent on finance.
Yes, just picking on what Eva was saying there about the individualism of countries and the evidence that feeds into the planning for those countries. At the moment, to be honest with you, if you look at the research agenda, most of it is focused in discovery science and biopharmaceutical research. And the work in context-specific areas, implementation science, operational science, participatory research that needs to be carried out in these countries is few and far between. And there just isn't been the focus by the research funding organizations in supporting that sort of work. And I think that feeds in, to a lot of the World Bank thinking on this, which is that at the moment, when you look at a lot of national cancer control plans, often they're what we call mimics. They've been written to try and mimic almost what we see in high-income settings. And it doesn't really reflect the reality of what's going on in the countries in terms of capacity and capability and the current state of outcomes, which, have, as Eva said, is unique for individual countries. And those things change, by the way, a lot over time. And so there's this recognition now from the World Bank that what we need to do is do a much, much closer focused cancer planning, which is relevant for that country over the forward period, say over the next 5 or 10 years, that also supports locally driven research in this sort of area that will inform future planning. What's, I think, going to really change things is when the financing comes through to support this sort of work. But to be honest, no country is going to be able to develop its cancer system without doing some form of this type of participatory research and policy work and health services research to actually inform local contexts. At the moment, we are extrapolating data from all over the world to model out, in inverted commas, the situation in lots of countries. And even within the cancer registers, as Eva knows well, the coverage still is absolutely shocking. We've been talking about proper cancer registration for what, Eva, 30 years? We keep saying, you need to fund this. This needs to be domestically funded. We need international funding. And it's glacial, the progress. It's been absolutely glacial. So people are happier to allow organisations to make up the modelling numbers than they are to actually pay for the data to be properly captured in a good quality register in a country, which, by the way, is the absolute backbone of cancer control. I think there's that recognition by the World Bank and from other major supranational organisations that the business as usual model we've had over the last 20 years is not really moving the agenda forward at the pace it needs to be to catch up with the size and the burden of the cancer problem.
I really think that's absolutely to the point. I have to say, we did some studies on a sample cohort and seeing how much treatment did patients actually get or not, and how was their survival. That's from sub-Saharan Africa, kind of as an example. It's not that one country does super and the others don't. It's highly diverse. Even in middle-income countries, we did a study with patients who were actually diagnosed between 2010 and 12. And now, again, we did similarly a study between 2019 and 2021, just before COVID, and assessed how high was the proportion of patients actually receiving guideline concordant treatment, where we did use the regional guidelines. And the good news was that we did see, with all methodological limitation, but we did see an increase in proportion of patients who had, let's say, care with minor deviation. But still, there were this proportion, which is obviously not accessing care at all. So I think that's what you're saying about having local solutions.
I guess when we stand back and look at systems, it's very hard because the sheer complexity of cancer with childhood cancers, blood cancers, the adult solid cancers. We tend to focus on 3 different cancer types as being indicators for how well the system's doing. And that's cervix, because it's a pelvic disease, breast, obviously, and interestingly, bowel cancer, because bowel cancer is rising rapidly in lots of transitioning countries, and it affects both men and women. And all of these 3 require very good surgery, good radiotherapy and systemic therapy. It's trimodality therapy, as we call it. So they're quite good at telling you how well the system's doing. And Eva said, the issue has been, if you stand back and look at the data, there are countries that have done really well. And then you get all these countries which are either flatlining or going down. In some cases, the going down is because of conflict and political instability. In other cases, they've not matured their health systems. It's not a problem with cancer. The problem is actually foundationally and fundamentally that the health system is not being financed, properly governed and developed. Cancer reflects all the strengths and weaknesses of our welfare and our healthcare system. And if you can't get those foundations right, you can have the best cancer plan in the world, nothing is going to improve. And I think it's fair to say in a lot of sub-Saharan African countries, the problem isn't the will behind the cancer control, it's the foundational bits of basic surgery, basic chemotherapy, basic pathways for diagnosis. That's my sense when you start looking and unpicking this, that we focus so much on the cancer expenditure when the problem actually rests in what we're spending on the social determinants of health, what we're actually spending on the basic building blocks of health systems. And I think if you start looking at it that way around, you can start unpicking what the problems are and start to point towards where solutions are and where you need patient and political activism to actually improve things, because that's the key.
So if we're looking at the building blocks of health systems strengthening as a core foundation to build global oncology and to improve those stats in not just those cancers, but others, Eva, you talked about working across disciplines, because often we hear the same problems, but we see the silos in disease categories. Can you tell us a little bit more about how working across different parts of the system can help build stronger foundations for cancer care?
I have one interesting example when we asked colleagues in Kampala in Uganda if they would be willing to do some interviews with patients to find out how and if they accessed care and what were barriers, etc. And then, in fact, because for some reason there wasn't really a person to do it, the oncologist actually did that. After that study, he called, I think, 50 patients or something. He said, Eva, that was so interesting, because those were population-based sample. And it was, in fact, he was calling the patients who actually didn't come to his office. And this was, for me, also highlighting how if you really have more discussions across these different areas, it really helps. And I think, of course, yes, there are countries where you have kind of cancer societies, where you have anthropologists, where you have nursing, where you have oncologists, of course. But I think this really has to develop. And when you have a country where you have 10 oncologists and 5 pathologists, what to do? That also has to be in a reasonable way. I see that there are more people with more education in so many countries. That's one point where I think that's an open door. The other point is I see much more private. First, I was really skeptical. How do you assure quality in areas which is not so much regulated by government? It's not so easy, but this has definitely improved the access to diagnostic services. And I think that's one of the key elements as well. And the other one is also that I would say that education and involving all levels of healthcare workers is very important, because if you have like a health center in a country with a young population where half is under age 15, that health center, maybe one breast cancer turns up a year. And bringing the care to the people is difficult in such vast countries where you also have so many young people who are not affected. On the other side, of course, the huge numbers eventually lead, for example, to numbers like Ethiopia, where you have 10,000 maternal deaths and 10,000 women dying from breast cancer. So it really has come up as a major problem. Those are women taking care of families and who are a huge part of the communities. Having adequate teaching and knowledge gained throughout the health system is really also one point where we have to find adequate and local solutions.
It comes back to those building blocks again, doesn't it, around regulation.
Absolutely.
And Richard, access to data. You said this is absolutely vital. We can't respond unless we know the situation. I think I would just like to talk a little bit about that. These building blocks are even more complex in conflict and crisis-affected settings. That's an area you work in, Richard. Do you want to talk to us a little bit about how that's different?
The estimates are now around 2.8, 2.9 billion people live in fragile, violence or conflict-impacted areas. But I think it's important to unpack that a little bit. There are areas where there is a frank war going on, and particularly the border between Russia and Ukraine at the moment, for example, Iran, etc. And then there are those individuals and countries that are caught up in conflict because they are host countries. So particularly when we think about the internal war within Sudan, with external actors pushing patients across into Egypt, into Chad, into Rwanda, what we saw from the civil war within Syria, pushing patients into Lebanon, Jordan, and up into Turkey. So all of these are very different ecosystems. And so when we've been thinking about what cancer control means, you have to go on one extreme. You're talking about cancer control within INGOs, international non-governmental organizations like the International Committee for the Red Cross, Médecins Sans Frontières, and what is a basic limited package you can put in to these deployments, all the way through to how do you support the Jordans and the Turkeys when they are having to look after tens of thousands of additional cancer patients in addition to their own citizens in countries that had limited capacity and capability in the first place. So it's a really interesting problem because the UN system does not have an easy solution to this. We haven't thought through the models of care for this. What are basic models of care that we ought to be paying for? And there's a lot of work that still needs to be done in this particular area, because unfortunately what we're seeing around the world is conflict and fragility is just growing and it's becoming more and more a part of everyday life, whether it's in the Sahel region in sub-Saharan Africa, the narco wars in Latin America. But this is going to require a very different mindset to financing, to care, and also particularly to transnational care, because you see a lot of people moving borders backwards and forwards. So it's lessons learned and actually coming up with essentially a very different package for cancer control, because it's beyond the national cancer control.
I think that's crucial in our discussions around equity to care as well. And transitional populations is one that's going to have to be a focus moving forward also. But we are running out of time already. So I think just a last reflection on how you've been working with patient-centered organizations. How are they involved in things like the cancer strategy for World Bank and other strategies?
I am very impressed how in all countries where we are working, there are patient organizations. Survivors speaking up and giving a positive reflection to really work on that vicious cycle in villages where a woman sees another woman having her breast taken off, losing her hair, and then dying anyway, will not lead to that woman going early when she feels a lump in her breast. So this point really needs local and, let's say outspoken patient organizations. We have produced videos and we have produced songs and, very innovative ways of spreading information that cancer can be cured. Of course, not all. And that is something very difficult to understand because, of course, there are probabilities and predictions, and bringing that together to such diverse communities is not easy. But I can say there are, very engaged patient organizations. And I think the stigma is reducing and patients are speaking up. And they are involved in cancer control plans, which I have seen. But maybe, Richard, you have other levels where you can see this, maybe?
Yeah, it's interesting. I think you're spot on, Eva, about women's engagement in this and the improvement in patient advocacy, particularly driven by women. And again, I think that speaks volumes to the elimination of cancer of the cervix programs, the global breast programs, etc. Where the deficit occurs actually is in men as advocates. And it's been remarkable. Even in the West still, it's dominated by women in terms of the advocacy programs. So for a lot of countries, trying to get the men to be activists as well is going to be really important. I think when we took a gendered view of cancer, particularly things like prostate cancer, which we talk very little about and has massive impact globally, bringing men into the fold and getting them to be political activists and to be pushing policymakers, I think would make the next big move forward. But I agree, like Eva, I'm very hopeful of the future where that's concerned, because as my colleague, Dr. Julie Trode, who reads all our patient advocacy work, will say, it's vastly improved compared to what it was like 10 years ago.
That's a really good place to close our discussion on a positive there. But we like to end our episodes with a piece of advice. So we have people working or beginning to work in this discipline of global oncology. What advice would you give to them when they really want to focus on improving equitable access to cancer care around the world?
The first point is to actually listen and to hear what are the actual challenges and try to get data, to try to get evidence and how to go for the low-hanging fruit or to how to really make a change according to how really people want it.
Thank you. So really listen and respond to what people want. I think that's a great message. Richard, a take-home message, please.
I think for this to improve, I think there's the 3 E's, the experience, actually building up experience of all these different systems and understanding how they do and don't work and what the different challenges are. Building up expertise in particular areas, hugely important, whether you want to be a health economist, a gynaecologist working in complex systems, and then also ability to read the evidence and actually not start from the beginning again, because there's a lot of evidence that's built up that people often fail to grasp. And I guess finally is work long-term with your friends around the world. At the end of the day, it is all about collaboration with friends and an idea of mutuality and solidarity, and do things together because it's the right thing to do.
Fantastic. So use the evidence that's there and build long-term relationships and work together. I really like that message. So thank you very much both for contributing to this discussion. And I really enjoyed learning about all the work that's been going on. Richard, we look forward to the strategy that's coming out, and Eva, also to your publications and learning around that patient focus and participatory research that helps us to make sure that the systems are developed how people want them and that they respond to the context where they're being delivered. This conversation reminds us that progress in cancer care cannot be measured by new technologies or treatments. It depends on whether health systems are financed, governed, strengthened in ways that respond to local realities, and whether patients and communities are part of shaping care. If this episode has been useful, please help continue the conversation by following Connecting Citizens to Science wherever you get your podcasts and sharing it with anyone interested in global health, cancer care, equity, or health system strengthening. Until next time, stay connected.